would be.
Okay. Before proceeding to CT, what are your differential diagnosis at this level?
At this level, it appears to be a benign looking lesion with narrow zone of transition.
Okay.
There is no evidence of cortical breach. I couldn't appreciate a soft tissue component in this scout film.
Okay.
There is some internal calcification, so I suggest it may be exophytic chondroma. Chondroma.
Okay. Okay. Yeah. You have CT. Yeah. As you told, we have proceeded with the CT. This is your CT. You just you can have the mouse control, right? Otherwise, you can request it.
Yeah, I can request it. Okay, I request it now.
Yes, you just click on the first image and start scrolling through the mouse button.
Yeah.
Yeah.
This is a CT scan of the same patient. Confirmed what I see in the scout film of exophytic bony component involving bony lesion involving the inferior, not the superior, inferior pubic ramus on the right side.
Okay.
And also I think it involves the superior also. With narrow zone of transition, there is no evidence of cortical breach, no evidence of surrounding soft tissue component. So I am going with a benign looking lesion, which could be osteochondroma. I would inform the referring physician about this finding and correlate with any previous available films to change of the size or history of the patient to evaluate any change of the clinical presentation and alert if any change in the presentation. I think MRI would be beneficial to exclude the possibility of carcinomatous transformation.
Okay, there are some more images in the same series. Can you scroll up and see?
Yeah, there is a transplanted kidney noted within right iliac fossa with heterogeneous density of the examined bones. So with reviewing these findings, I think possibility of brown tumor must be considered in a patient like this.
Okay.
No other findings could be detected in this examination.
Okay. Yeah. What do you do next?
I think correlation with laboratory investigations and parathyroid hormone would be considered for excluding the possibility of secondary hyperparathyroidism.
Okay. Yeah, chest pain.
This is a frontal chest radiograph of skeletally mature patient complaining of chest pain. Revealed the left apex appear relatively hyper dense in comparison with the right side. However, I will go systematically with this patient to exclude other pathology other than this. Mediastinum appear okay, retrocardiac shadows, no retrocardiac shadows, subdiaphragmatic region appear intact. The bony skeleton around this left apical lesion appear unremarkable with no evidence of bone destruction or no evidence of other bony lesions could be detected on the right side. I think this lesions is raising the possibility of Pancoast tumor. I will inform the referring physician about this findings and correlate with any previous images to compare with it and arrange the patient for CT chest, abdomen, and pelvis for staging of this lesion, which could be Pancoast tumor.
Okay. The previous chest X-ray, we reviewed the previous chest X-ray. It was almost the same 5 years back also.
5 years back, I think it going with a benign cause, maybe pleural lipoma or something benign, I must suggest in this setting.
Okay. So in which compartment of mediastinum do you think this lesion is?
I think this lesion appear to be posterior because there is no displacement of the trachea.
Okay.
And the medial border of this lesion I couldn't detect sharply, like the superior and lateral borders appear more sharp than the medial border. So I suggest it is a posterior mediastinal mass.
Okay.
Maybe neurogenic, other possibility of neurogenic mass could be considered, but soft tissue revealed no neurofibromas in this image.
Okay, so what do you do next?
I think CT would be beneficial in this case.
Okay, yeah, as you told, we have CT. Feel free to scroll. Okay. Just click on the center of the image and scroll.
I think it's going around. Yeah. I will take a look on the full exam, and after that I will go through.
Okay.
I was provided with axial CT chest with IV contrast in mediastinal window revealed. It confirms that this is a posterior mediastinal mass, which is adjacent to the posterior extent of the upper ribs and the spinal canal, and there is no definite intraspinal extension I could detect in this case. However, still the possibility of neurogenic tumor like schwannoma is the first possibility in patients like that. Okay. Other possibility would be considered as extramedullary hematopoiesis. However, it is less likely because there is no evidence of other lesions. It comes usually more than one lesion. In this case, there is no evidence of splenomegaly within the upper abdominal cuts appear unremarkable. Adrenal glands and kidneys also appear unremarkable. Okay. In my routine practice, I would like to see the lung window to evaluate the both lungs in case like that.
Okay. Yeah, lungs were clear. Okay.
Okay, I will inform the referring physician about that, and I think they may arrange for biopsy.
Yeah, your next case, admitted following trauma at home.
Okay. I was provided with a bone scan of patient who admitted with trauma within home revealed. There is non-visualization of the soft tissue of both kidneys with diffuse slight increase tracer uptake within the bone skeleton, whole bone skeleton, and there is evidence of full scaster inserted. This picture is suggestive of prostatic problem with possibility. However, the lower limbs is not taken so much like the, and the upper limbs also is not taken like the axial skeleton. But these findings is suggestive of sober scan with possibility of diffuse prostatic metastasis. I would inform the referring physician about these findings and arrange for serum BSA and other investigations to exclude the possibility of prostatic carcinoma.
Okay, so what are the other causes of superscan?
The other causes of superscan include metabolic causes like hyperparathyroidism, okay. Metastatic diffuse sclerotic metastatic disease, and I don't remember.
Okay, yeah, that's okay. Yeah, this is a patient with a sigmoid cancer, known patient of sigmoid cancer. Then they saw a adrenal nodule on CT. Mm-hmm. Now this is the study. Click on the center black button and feel scrolling. You can take the series of images from the left side corner.
Okay.
Yeah.
So I was provided with axial MRI T2 weighted sequence of patient with known cancer colon with right adrenal lesion, which is suspected to be a metastatic. This lesion is presenting T2 hyper intense in comparison with the liver, the adjacent liver. When we take T2 fat set, we found that the lesion revealed no fat saturation, so there is no fat content inside. When we go to T1 is presenting hypointense signals in comparison with adjacent liver. With contrast out of phase, T1 out of phase, it is suggestive of containing fat content because there is a drop of signal within out of phase series. So I think these findings are raising the possibility of incidentaloma of right adrenal adenoma. And in my routine practice, I would compare these findings with contrast enhanced T1, and we may arrange for CT adrenal protocol, which also, however, these findings are going with adrenal adenoma.
Okay, CT contrast adrenal study was not performed because of high creatine levels of the patient, and these are the study we could able to obtain from the patient to rule out. The surgeon is asking whether I need to take out the adrenal gland or not.
I am going with this adrenal gland that appear to be adrenal incidentaloma, adrenal adenoma, just containing fat because it drops signal within out of phase series.
Okay, so you don't think any metastasis, right?
No.
Okay. Yeah, this is a 4-month-old infant presenting with medical issues since birth.
Okay. This is frontal chest radiograph of skeletally immature baby, which appear to be term baby because I see the epiphysis of humerus bilaterally. The examined mediastinum appear intact with prominent thymus gland. The lung fields bilaterally appear also intact. Chest skeleton bilaterally also appear unremarkable. Subdiaphragmatic region revealed increased bowel gases. However, there is no evidence of pneumoperitoneum or portal venous gas could be detected within this film. So I didn't appreciate significant abnormality in this film.
Okay. The clinicians are suspecting some congenital bony disorders in the child, as it is evident in the parents also.
Bony problem.
Sorry, Dr. Anil, 15 minutes are over.
Yeah,
so
this is the last case. You finish this and we'll stop.
Okay. The cervical spine, I think there is widening of the interpedicular distance.
That's okay. That's normal.
I couldn't appreciate significant abnormalities. Sorry for that.
Okay. Can you? We'll stop this. So we'll review the images, the cases now. Can you see the clavicle here?
Oh, sorry. Cleidoclavicular cranial dysplasia. Yeah.
Yeah, this is absence of clavicles. Both
You
clavicles
are
are
right.
absent,
You are right.
and
I need to go. I didn't go systematically in this case.
yeah,
Okay.
and the baby has been imaged with a skull also. Can you see? Can you describe this skull?
Yeah. There is widening of the fontanelles with much more what they called small ossicles or
Wormian bones.
Wormian bone. Yeah,
Yeah.
increased Wormian bone. Yeah, you are
Okay.
right.
Okay. Okay. Yeah. Yes. Good. You did well. This is a case of cleidocranial dysostosis in the absence of bilateral clavicles.
You
So
are
this
right.
is very much important when you when you see a case. The abnormality which is bilaterally symmetrical, it's very difficult to pick up by human eye.
Yeah.
Yeah, that's the one thing. This case is for that only. So, and remaining case, how do you think how the cases went for you?
I don't know. You tell me, but these are very good cases in my opinion. But
Yeah,
you tell me what I did. I don't know.
yeah, you did well. You picked up all the diagnosis.
Thank you.
Yeah, yes, that's good. And this is the case of adrenal adenoma. As you see, this is clear-cut fatty. This is clear-cut dropout of signals when
Right.
compared to in phase and out phase. So this is a case
That's
of
good.
benign adrenal adenoma. So this is nothing to do with the metastasis. So initially on initial sequences, you told there is no fat suppression and on the fat sat and no fatty lesion.
But here in Tito, Fat said, I didn't see there is a suppression, really.
Yeah. Okay. Yeah. Before commenting anything, you just look at the all the series, and if all the series are not provided, you just ask for the series. So here we can see the series, but in exams you can't see the series. You should ask. You should ask for the series. Okay.
So I must ask
Yeah.
out of phase before
Yeah. In
conclusion
phase
that
and
there
out
is
of phase is the sequence for adrenals.
right. You are
Yeah,
right.
that's the main sequence because here in UK, adrenals study of adrenals is a major thing. That's why.
Right.
Okay, yeah. Apart from that, previous one is this is a classical case of super scan. Again, the nuclear medicine scan is also one thing which we won't touch up in the preparation because that is a routine thing done here in UK, and you need to be very much clear of nuclear medicine study. So this not only bone scan, many studies are also being done. So again, this is a super scan, and this the bladder catheterized, and the contrast means the radioactivity in the catheter. And yeah, again, as you told, diffuse increase uptake in the bony skeleton, suggestive of metastasis. Yeah, this was a case of prostatic metastasis, and PSA was sky high.
What is the other causes of super scan? Can you remember me?
Yeah,
Please?
as you told, yeah, this the metabolic one and metastatic one. Metastatic one, prostate in men and breast in females.
Breast adenoma.
Yeah, metabolic one is hyperparathyroidism and other causes. Yeah.
Yeah, you are.
Yeah, this is a classical case of benign thing. And what do you think the age of the patient?
Skeletally mature patient.
Yeah, around 20s, 30s. Yeah, this is a very young patient. So in a young patient and well-defined opacity, Pancoast tumors will be very less likely, and there is no bony erosion. And you told no bony erosion, and you told of Pancoast also, which go against each other. So that's why you should be careful in your words. Okay.
Yeah.
This is very much benign. Yeah, don't commit for a diagnosis at the first instance. You just keep the differential diagnosis wide open. Then you arrive at the diagnosis at the end of the this one.
You are right.
Yeah.
Because if I give diagnosis, I need to change at the end.
Yeah, that's the difficult thing. Once you give the diagnosis and changing the diagnosis is difficult than to keep a differential diagnosis.
Right, you are right.
Even after examiners are insisting you to give a one differential diagnosis, either one of them, then you can choose one out of two. Okay.
Right.
Yeah, this is a case of neurofibroma. As you see, they did MRI also. Posterior mediastinal neurogenic tumor. If you tell a neurogenic tumor, that's enough.
Right.
Okay. Yeah, this is one. And the previous case was, yeah, this is again good case you have picked up. This is a case of transplant kidney of a chronic CKD patient and multiple expansile expansile lucent lesions with narrow zone of transition. Again, the bone tumors are very favorite for FRCR examiners, and CKD is also very favorite because all kinds of hemodialysis catheter, and X-rays of all kinds of hyperparathyroidism, including erosions of the clavicular ends, and those rugged spine, those things can be kept in exam also. Okay.
Okay, but the final diagnosis in this case.
Yeah, Brown's tumor, secondary hyperparathyroidism because of CKD and the transplant kidney.
And the Brown's tumor come exophytic like this, or expansile like this.
Yeah, expansile.
Ah, okay.
Yeah.
Thank you very
you did well. Keep it up. All the best.
Thank you, Dr. Anil.
Okay. We'll go for the second one.
Yes. Hello.
Hi. Yeah, this is your case, first case.
Okay, so I'm presented with a frontal AB radiograph of the abdomen, and I can see that there is abnormal gaseous or hypodense shadows seen projecting over the right kidney and a right renal shadow. There is no evidence of bowel dilatation, and by reviewing the bones, I can see no major abnormalities. So I need to review the clinical history of the patient regarding renal pathology, maybe renal condition.
Yeah, the patient presented with right lumbar quadrant pain, and pain radiating from, not radiating, with raised inflammatory markers.
Okay, so regarding gaseous shadow projecting over the right renal shadow, I'm suspecting maybe emphysematous pyelonephritis, maybe. In the same area also is gallbladder, so but it's not the shape of the gallbladder, also maybe emphysematous cholecystitis. So I need to review with CT with contrast for further CT for further assessment.
Okay, yeah. Before CT, what do you want to ask the clinician? One history.
In the history?
Yeah. What do you want to know?
If the patient is diabetic?
Yeah. Okay. Yeah. As you asked, CT is here. You can just scroll.
I will ask for remote control.
Remote control. Yeah. Ask for remote control. Yeah. Click on the center of the image and start scrolling.
Okay. So this is coronal CT non-contrast and of the abdomen, and it shows multiple flecks of gas seen surrounding the right kidney and within the right renal parenchyma as well, and with multiple fat stranding. And the right kidney appears enlarged with surrounding fat stranding and fluid signal. So this confirmed the diagnosis of emphysematous pyelonephritis.
Okay. What do you do next?
This is emergency. I need to urgently inform the clinician. So because this is show high mortality rate, and we it needs antibiotic therapy, maybe a drainage or drainage. Yes.
Okay. Next case.
Yes. Okay. So this is AB radiograph of the chest, and I can see that there is decreased lung markings seen on the right upper, not decreased. It's not seen on the right upper hemithorax with faint line, maybe suggest a faint pleural line suggesting a pneumothorax on the right side. And otherwise, the lung fields show reticular shadows seen mainly on the lower zones, cardiac shadows normal, and slightly there is some preserved lung shadows or preserved lung volumes, or even mildly enlarged lung volumes, no hilar enlargement, and the the bones are fine, I think. So this is I think right-sided pneumothorax, and it's I need to urgently inform the chest physician for pneumothorax, and maybe I need for further assessment with CT to see the underlying pathology if this patient is not post-traumatic. So I need to do HRCT to assess the pathology.
Yeah, there was no history of trauma and it was very spontaneous chest pain. Yeah, one question, the clinician want to put a drain. What do you say?
Drain?
Drain, chest drain.
Chest drain. Okay, there is pneumothorax, but
okay, will you put no, he's asking you to put a chest drain.
For me, no, I will not put the chest drain. It should be referred to first it should be referred to the interventional radiologist, maybe, or chest
okay
physician.
You are the interventional radiologist.
Okay, I don't know.
Okay, yeah, this is a very small pneumothorax and it is not causing any mediastinal shift and not causing much symptoms and saturation, loss of saturation. That's why we followed it up with a series of X-ray. And the lady again presented 12 weeks back, 12 weeks later with this chest X-ray. So what do you see?
Okay, so I in this chest X-ray, now following the pneumothorax, I can see there is I'm not clearly seeing the pneumothorax actually on this scan.
Okay.
And there is bilateral basal reticular shadows still seen.
Okay, so what do you think the cause of pneumothorax?
Cause of pneumothorax, maybe lung bolus or cystic lung disease. Maybe
okay, yeah, we are not seeing any bulla or something like that. Again, we proceeded with the CT as you told. So this is the CT. This is the only static image we have. Rest of the lungs were clear. So what do you see?
Okay, so this is single cut through the upper through the middle chest, and I can see that there is not a diffuse nodular pattern around the glass pasty within that. Okay, but I can see the pneumothorax. So I'm thinking there is no effusion, there is no evidence of bronchiectasis. It's just nodular pattern, single image.
Now, this is the only abnormality we saw on CT. So what do you think of this?
It's not, it's a peripherally located nodule. It's a subpleural nodule.
Yeah.
And subpleural nodules can, I need to review the rest of the imaging. Nodules with pneumothorax, I will think of LCH, maybe. So I need to review the rest of the images. Otherwise,
the rest of the lung was clear. This is the only nodule in the entire thorax.
The only nodule on the thorax. Okay. No. Should I give the diagnosis?
Yeah, differential diagnosis is also fine.
Okay, so for subpleural nodule, I can say it can be sarcoidosis, part of sarcoidosis, or can be part of lymphangitis carcinomatosa, or can be part of Langerhans histiocytosis.
So, okay, which of them cause pneumothorax?
LCH.
Okay, are you sure?
LCH cause pneumothorax, LAM cause pneumothorax, but yes. LAM shows no nodules, and LAM just a thin-walled cyst.
Okay, okay. Yeah, we will come back to this case again, okay?
Okay.
Next case. Yeah, these are a series of CT MR images. You just click on the MRI center of the image and start scrolling. You can take the series also. Presented with headache.
Headache, and this is MRI of the brain. FLAIR images, and I can see that there is other than bilateral periventricular multiple high signal intensity foci, there is right frontal cortical hyperdensity, and there is opacification of the left frontal sinus, and as well as both ethmoid sinuses. Okay, maxillary sinuses as well showing thickening. There is some increased density within the occipital horn of the left lateral ventricle. Can I see other sequences?
Yeah, you can. Feel free to take other sequence also. Yeah, click on them. Any sequence, whichever you want.
I need to see T1 first. T1.
Yeah.
Okay.
Patient is telling he has some clear fluid coming from his nose. Some water.
Clear fluid coming from nose.
Yeah, some water.
Okay.
Water is coming from his nose continuously.
Okay, so just okay, so there is communication between the CSF space in the anterior cranial fossa and within the within the nasal cavity, with the CSF seen within the right upper part. So this is, I think, encephalomyelocele. Sorry. Yes.
Okay. Yeah.
Herniation. Yes.
Okay. So what do you do?
Okay. I will refer to the neurosurgical team for further management of this defect repair with
Okay.
surgical management. Yes.
Yeah. Good. Next case.
Okay, so this is frontal radiograph of the chest of skeletally mature patient, and I can see that there is endotracheal tube and multiple ECG leads indicating patient is unwell, and I can see that there is diffuse bone sclerosis with bilateral upper zonal opacities seen, ill-defined opacities. Cardiac shadow is unremarkable, with no pleural effusion, and
Patient is acutely unwell following trauma.
mild prominent. Sorry?
Yeah, patient is acutely unwell following trauma.
Patient trauma. Hello?
Hello, can you hear me?
Hello?
Yeah, can you hear me?
Trauma, yes, okay.
Yeah.
So I need to search for, first of all, I need to search for factors. And yes, Dr. Anil, yes, I can hear you, yes.
Yeah, patient is acutely
Okay,
unwell.
I'm searching
following
now
trauma.
for fractures. So reps are fine. I can see no evidence of bone fractures. Actually, I can't see, but this bilateral upper lobe opacities may represent lung contusions. Also, I can't.
I think we lost Iman. Asad?
Dr. Asad, can
I'm
you?
sorry. I'm sorry.
Okay.
Yeah,
I was.
got her back.
I'm sorry. Okay, so this is a supine patient, and I think there is deep left-sided sulcus, which may suggest that there is underlying pneumothorax on the left side. And the right costophrenic angle is unremarkable, but the left is slightly deeper, which suggesting pneumothorax, and there is bilateral upper zonal opacities may represent contusions.
Okay, yeah.
I
What do
can't
you
see
do?
any other fractures.
Okay, what do you do next?
Either I will do erect to confirm the standing to confirm the pneumothorax, or I will proceed to CT to confirm the diagnosis and exclude other subtle fractures, maybe.
Okay, good. This is the patient who underwent open heart surgery and centerline insertion, and now he is presenting with some upper abdominal and facial symptoms.
But time is over.
Okay, yeah, that's okay. Iman, are you here? Yeah.
Yes.
How do you think the Viva went?
Not very well.
No, you did well. You picked up all the findings, and you should be yeah, as you are telling, you should be little quick and arrive at the diagnosis at the earliest. Yeah, you are right at the diagnosis. This is a supine pneumothorax. You can see the deep sulcus sign. Yeah, one thing you should remember in FRCR exam, you should never miss an emergency. So that's what they look at in the candidates, whether he can able to do a on-call duty on his own. That's the purpose of FRCR. You see FRCR candidates, it is ST3 candidates, year 3 radiology residents who will go into year 4 to manage the duties independently. That's the criteria. That's what they test in FRCR exam also, whether you can manage emergency, and you should not miss an emergency. That's the life-threatening one. So this is a supine pneumothorax, and you picked out very well. However, there are no fractures. So everything, lines and tubes are fine, and you should immediately inform the clinician. Okay, that's
Yes.
good. And yeah, previous one, yeah, this is the encephalo meningocele, and through the defect in the cribriform plate and the herniation of the brain parenchyma, patient had a history of trauma 2 years back. Okay.
Okay.
Good. And yeah, this is a case of catamenial pneumothorax. Patient had endometriosis with a deposit in the right lung. This is the nodule, subpleural nodule, and this nodule was rupturing and giving the pneumothorax every month or 2 or 3 months, like that.
Oh,
So
okay.
monthly, she used to get this kind of pneumothorax and presenting with a series of X-rays. You saw? This is the first
Yes.
X-ray with pneumothorax, and again she recovered, and again after 12 weeks she presented with again pneumothorax. So differential diagnosis can be, as you told, one I expected metastasis. Metastasis will also give this kind of pneumothorax, but not in series. But you should consider metastasis as DD and LAM also. LAM cause pneumothorax and chylothorax also.
Okay.
Less likely LCH. LAM more than LCH. Okay.
Yes.
Yeah, in younger patient, osteosarcomas give pneumothorax. Okay. And the previous one, yeah, this is your first case, and you picked up very well. This is the shadow in the right lumbar region, and you clearly write in asking the history of diabetes, because emphysematous cholecystitis, emphysematous pyelonephritis, cystitis, all are common in diabetic patients. Yeah, and this has to be acutely managed in emergency setting. Okay.
Yes.
Yeah, good. You did well. All the best.
Thank you. Thank you.
Okay, yeah. Shall we move on to the third candidate now?
Who is going next?
Hello. It's me. Hello.
Pfizer?
Yes.
Yeah, this is your case.
I am provided with the bilateral mediolateral oblique views of the breast, and I can see multiple well-defined rounded nodular shadows overlying the both breast, and these appears to be related to the skin, as I can see the halo around these soft tissue nodules. The breast parenchyma appears to be fibroglandular. I can see an ill-defined spiculated soft tissue lesion in the upper part of the, I think, right breast, and there is adjacent. There is
which is right, which is left among these?
This one, I can see this lesion. Sorry.
Which
Yeah,
one?
this
The
one.
lesion is in left breast or right breast?
Sorry, left breast. Sorry.
Okay, yeah.
And
But
it is there is adjacent speculation, and I cannot see any amorphous calcification within the lesion. I would like to have the magnified views of the lesion, and on the basis of this imaging, I will consider it as a highly suspicious for malignant lesion on the background of likely neurofibromatosis, and I will advise the ultrasound of the breast and refers to the breast clinic for ultrasound and exam of the breast, and as well as refer for the biopsy of the lesion.
okay, okay. So what is one-stop clinic?
It's basically for the evaluation of the breast lesions, and there they do the examination, clinical examination, as well as ultrasound of the lesion, and also refer the patient for like accelerate the patient's pathway, because if it is highly malignant, they will do the biopsy, arrange the biopsy of the lesion as well.
Okay, yeah, great. Anything else you want to see in this case?
As I mentioned, there is background neurofibromatosis, and there are multiple nodules. I can see the some lymph nodes in the axilla, but they appears to be within the normal limits to me.
Okay, okay.
And
That's okay, fine. Next case. Click on the, you ask for the remote control, please.
okay.
Okay, yeah. Click on the center of the images and start scrolling.
Okay.
Use the scroll button or the arrows.
Okay.
Yeah.
So I have been provided with the just.
You need to use the scroll button.
Yeah.
Of your mouse. Yeah.
Yeah. Thank you. So I have been provided with the contrast and has CT abdomen, abdomen pelvis of a male patient. I can see there is a the left kidney is grossly hydronephrotic with the peripheral rim or cortical rim of the normal parenchyma. There is a ill-defined soft tissue attenuation mass adjacent to the kidney and in the left para-aortic region, and it is extending from the lumbar region up to the sacral area. There is also umbilical hernia with omental herniation through it, and I can see it is extending between the vertebrae and aorta, and it is also causing and showing mild contrast enhancement. So my differentials would be, and it is causing the obstructive nephropathy and causing the hydronephrosis on the left side. For this mass, my differentials would be lymphoma. It could be the retroperitoneal fibrosis, and I would like to inform the clinician about the findings. I will also like to see the lung and other liver and pancreas and spleen appears to be unremarkable. And I would like to
Okay,
inform the clinician about these findings, and I will urgently refer the patient for the to relieve the obstruction in the left kidney, as it is more urgent to me at this moment. And after that, I will advise the further referral to the patient to the gastroenterology team for the discuss the patient in MDT and further manage the patient accordingly.
Okay, how do you manage next? Further means next, what is the next step?
First, I will like to ask the clinician to relieve the
After that.
hydronephrosis.
Okay, after that.
After that, the biopsy of the lesion.
Okay. Yeah, biopsy. They did a biopsy, and it turned out to be a metastatic lesion.
Okay, so I will. It could be metastatic. I cannot see grossly any abnormality in the visualized, so I will advise the CT thorax and chest. It might be from primary from the chest.
Yeah, CT was normal. CT thorax was normal.
Okay, so I will like to see the other.
Now the question is, where is the primary? The clinician.
Yeah, so I would like to see the images, other images. There might be the other. On the corner images, the bowel appears to be unremarkable, and the mass is encasing the aorta, and it is adjacent to the renal pelvis.
Yeah, where do you think the metastasis has come from? Where do you think the primary is?
In the male patient, it could be it could be the from testicular tumor in this area, because it's around the para-aortic region, and
Okay.
there are the.
Yeah, what do you do next?
I will like to do the ultrasound of the testes.
Okay.
And it is the ultrasound scan of the left testis, and I can see an ill-defined mixed echogenic lesion in the left testes, and I would like to assess with the Doppler color so that to assess the vascularity of the lesion, and with the there is irregular margin. It is within the testicular testes, and I cannot see any gross hydrocele or any adjacent.
Okay. Yeah. What do you think?
So it's a metastatic that mass in the abdomen para-aortic region is metastatic lymph node from the primary in the left testes.
Yeah. What this could be? Primary.
It could be seminoma.
Okay.
And
yeah, other tumors also, other testicular tumors also.
Yeah.
This 75-year-old male presented with very bowel obstruction.
Okay, I am provided with the chest frontal abdominal radiograph of 75-year-old male, and the bowels appears to be non-specific shadowing shadows of the bowel, and I can see the gas in the rectum as well, in the sigmoid and rectum as well. I can see there is a ill-defined sclerosis and mixed sclerotic lytic lesion in the left upper femoral metaphysis and extending to the neck, and it appears to me like old healed fracture neck femoral neck fracture.
Okay.
But
there was no history of trauma.
So it appears to be pathological because there is underlying bone deformity. Like I can see the mixed lytic sclerotic lesion. I would like to have the X-ray of the left femur as well, and there is also the irregularity along the left iliac blade.
Okay. Yeah, as you requested, here is the film of femur.
So it's the chest X-ray left femur frontal projection. There is marked sclerosis and bony expansion and bone remodeling of the left femoral metadiaphysis, and there is coarse trabecular pattern. I can see also a lucent line here along the lateral cortex of the femur. So it could be in this age group with the marked bony expansion and cortical thickening and bone remodeling. My first the differential would be the Paget's disease, and with the I'm not sure, but it could be the banana fracture, and I would like to advise the clinician to correlate with the serum calcium and phosphate levels. And
yeah, they were normal. Serum markers were normal.
Serum markers were normal,
including the alkaline phosphatase.
Alkaline phosphatase. Okay.
Yeah.
So it could be in this age group, it could be metastatic disease, but it won't be like it's involving from one part of the bone and extending up to the mid diaphysis.
There is no history of any primary tumor in the body.
Okay. So it could be but fibrous dysplasia is not in this age group.
Yes, you are right. This could be a fibrous dysplasia. It is this fibrous dysplasia.
Okay, so
yeah. This can happen at a 75-year-old age also.
Yeah.
You should be a little more confident in your answers. Okay. Yeah.
Okay.
Move to the next one.
Okay. Thank you.
Yeah, this is the patient, 50-year-old female presenting with left arm tingling sensation and decreased sensation.
Okay.
Yeah, click on the image and
okay.
Scroll.
So I'm provided with the non-contrast CT brain of a 65-year-old female who is presented with tingling sensation and unconscious.
And numbness also numbness. Of the left upper, yeah, left side.
Left side, upper arm. So I am scrolling from vertex down, and bilateral ventricles appears to be normal, and there is brain parenchyma is preserved. I cannot see any gross abnormality within the brain parenchyma, and there is cortical and
okay, the clinician is suspecting stroke.
Yeah, I cannot see any hyperdense area which is involving gray and white matter in the
patient has left hemiplegia, some sort of left hemiplegia.
So in
okay, what do you do? What do you tell the clinician?
I cannot find any hypodensity at the moment. It might be the early scan, or so I would like to ask for the MRI so that, because it can pick the any ischemic changes early.
Yeah, MRI is here. You can take any sequence you want.
Okay, so I'm provided with the MRI brain of the patient.
Which sequence you want to see?
So yes, so on the MRI, sorry, scrolling so fast. So on the T2 weighted images, I can see there is a increased signal intensity within the right temporal lobe, and I would like to see the flare images.
Sorry, time is up.
Yeah, we will finish this case.
Okay. So their hyperintensity is seen in the right temporal lobe, and it is, and I would like to confirm my findings with the diffusion weighted images.
Yeah, this is diffusion.
Sorry, yes, this is called increased signal on the diffusion weighted, and because of this area, it is the temporal, it is the infarct, and
okay, yeah. What do you tell the clinician?
So I will ask I will refer the patient to the stroke team, because as it's early and patient might be in the thrombolytic window, so I will refer the patient for the thrombolysis.
Okay, yeah. Do you want to have a look at CT once again now?
Yeah. It might be the dense MCS.
Yeah, one second. I will load the CT.
Yeah.
Can you see the abnormality? Can you see the
Yes.
structure? What is this?
So it's a hyperdense posterior cerebral artery.
Yeah, PCA. This is a hypertense PCA sign.
PCA sign. Yeah.
Yeah, this is the acute PCA territory infarct
Yes.
with thrombosis of artery.
Yeah.
Okay, yeah, good. Yeah, you did well. As I told you, there's the emergencies is the main thing in FRCR exam. You should not miss any emergencies, and you are confident. You should be more confident in your diagnosis. You know your stuff. You should be more talkative and more confident, and come at the diagnosis at the earliest moment, so that you can see more and more of cases. Okay.
Okay.
Yeah. This is the right PCA hypertense sign and acute infarct. Okay.
Okay.
No complications thing. And this is again you picked it very well. This is the bony abnormality at the edge of the film. 1 or 2 cases you will get abnormality at the edge of the film. You should see everything in the film and come at the diagnosis. And this is a case of fibrodysplasia. Fibrodysplasia can happen at elderly age also. There is no age bar. So this is a case of fibrodysplasia. As you were right in telling the Paget's is also in differential diagnosis.
Yeah.
That's right. Okay.
Okay.
And you should see anywhere else other bones are also involved in the body or not. Okay.
Okay.
Yeah, this is a metastatic one. You should always consider metastasis in male patient in para-aortic lymphoedema. This is a nodal mass, primary being from the left testis.
Yes.
Yeah, you are right in managing acute left kidney, and you should be telling the ultrasound of scrotum before pumping. Okay. Yeah. Okay. Good. And again, this is a good case with carcinoma in neurofibromatosis patient. And one more thing I forgot, you didn't ask for the CC view.
Yeah.
Yeah, that's the main thing. You cannot arrive at the diagnosis in one film, one set of images, and you should always ask for both the views. That's the main criteria. And in earlier exams, we used to put up the films like this, where whether you should keep the right to the right side, left to the left side, and CC view. That's how. But now the images will be loaded on a system. Anyway, you should ask for those CC view also along with the MLO. And one-stop breast clinic is same as you told. Patient come for the clinic and they will undergo breast examination by a clinician and ultrasonography and image guided biopsy. So these are 3 things. So these 3 things happen in one day. Okay.
Okay.
That's called one-stop clinic. There are no need to come again and go back like that. Okay. All the diagnosis will be happening in one day. That's how it's called one-stop breast clinic. Okay.
Okay.
Yeah, good. You did well.
Thank you so much.
Yeah.
Thank you.
All the best.
Very nice cases. Thank you so much.
Okay. Yeah. Shall we move to next candidate? Asad?
Yes. Who is going next?
I am next, I think.
Yeah. Mohan?
Dr. Mohan?
Yeah, I am here.
Okay.
Yeah, this is your first case.
Okay, I am given image of micturating cystourethrogram I can see the bladder is irregular with multiple trabeculae and circulations. So I'm thinking of chronic bladder disease, like chronic cystic changes. It can be neurogenic bladder. It can be as in case of neurogenic bladder or in case of tuberculosis. So I would like to see. I would like to take the history of the patient to rule out neurogenic bladder.
Okay. What history you want to take?
Is there any neurological deficits or like anything known disease suffering?
Okay. Can you see any evidence of neurological deficit in this image?
Neurological deficit. I don't see any obvious hypoplasia or nothing like that. So only thing is the obvious feature is the irregular bladder wall with the trabeculations.
Okay. Yeah. What about this?
I can see the sacrum. Sacrum is not visible in this X-ray.
Okay.
So maybe there is agency of sacrum.
Okay. Yeah. What do you do next?
Next, I would like to do MRI spine to rule out for any cord involvement, anything.
Okay. Yeah. As you told, we have proceeded with the MRI spine. Ask for control.
Yeah. Control. I don't know where is the control options.
Yeah.
You can go to the view options, click on the view options, and it will show you request remote control.
Multiple participants. I'm sorry, I'm not able to pick up where it is.
Yeah, this is, I think you are controlling the screen now.
Yeah, I'm controlling this. Sorry. I'm giving it a MR image of lumbar spine, T2 weighted images and sagittal view.
Okay.
So I can see there is I can see there is the level of conus terminalis is at the lower level. Maybe corresponding to the L4, L5. So I think I some suspicion about the tethered cord in this.
Okay.
Tethered cord, and I don't see any lipomatous component here in this to think of any lipomyelocele here.
Okay. No, on the X-ray you told something about the sacrum.
Sacrum, yeah, sacrum. I told it was urgent, not seen, but here I can make out sacrum. This MRI view.
Okay.
Sacrum is seen, and I would like to see any bony defect in the spinal canal. I would like to see the axial views once.
Yeah, there are many other sequences. You can take the
So I'm going down. Okay, in the sacrum, maybe in the S1, I think there is some laminar defect on right side.
Okay.
Laminar defect. And
okay. Do you want to look at the axial T1?
Yeah. The lumbar spine appears fine. No evidence of any obvious bony defect.
Okay.
And coming to the sacrum, yeah, there is some defect in the maybe in the S1 vertebra on the right side. The laminar defect is there.
Okay.
I don't see any obvious extrusion of any canal content outside any lipoma or any lipomeningocele outside
Okay.
the spinal canal. In this,
Can you go up in the same sequences? Yeah. What is this?
this is in the given sequence. It should be like fat component. I think lipoma.
Okay. Okay. Yeah. What's your final diagnosis and how will you manage?
Okay, I think this is a case of lipomyelocele with no evidence of any exclusion of intraspinal contents. So there is a threaded cord in this.
Okay.
Threaded cord with lower attachment of the cord. So with neurogenic bladder, I would like to refer this patient to the neurophysician and also inform the findings about the cord involvement and neurogenic bladder.
Okay. Yeah. Your next case.
Okay.
Click on the center of screen and start scrolling. Yeah. You can
I'm
take any
given,
other sequences you want. Okay.
Okay, sir. I'm given MRI images of spine showing the cervical-dorsal spine T2 sequence. The cord appears normal in caliber and no evidence of any abnormal hyperintense lesion within the spinal cord. The adjacent vertebrae are fine. No evidence of any tonsillar herniation in the foramen magnum.
Yeah, the patient
I
panel is right-sided.
I can see there is a widening of neural foramina at maybe around lower cervical level. So maybe this can be case of meningocele, lateral meningocele, or can be case of neurofibroma in a case of NF1.
Okay.
I'd like to see axial sections once to confirm my findings.
Yeah, there are axials.
Okay, yeah, as I can see, there is widening of neural foramina with T2 hyperintense signals coming through it on the right side in the lower cervical region. So it can be a lateral meningocele, lateral thoracic meningocele, and I don't see any obvious cystic lesion over that or any obvious vertebral defect to tell it as neuroenteric cyst.
Okay.
So yeah, my primary diagnosis is lateral thoracic meningitis. I would like to rule out other features like of NF1 in this patient, maybe in the brain or like another systematic.
There are no features of NF1. And what do you do next? How do you manage?
I will refer the patient to a neurology team, and I would like to do the genetics screening of this patient for
Why
NF1.
genetic screening?
Is there a history of any trauma of this case?
Yeah, there was history of difficult labor. He's a child of 11-year-old.
Okay, so if it is a case of trauma, then I suspect pseudomeningocele in this case with root avulsion.
Okay. Okay. Yeah, your next case.
Okay, I am given X-ray of test X-ray frontal view of a skeletal immature patient. I can see there is inhomogeneous opacity in the left mid zone. And no evidence of any calcification, and there is no evidence of any obscuring of the left lateral border of cardia.
Okay.
Then what is the bones around the region or and the abnormality appears fine.
Okay. So what do you think it is? What are the possibilities?
It can be consolidation.
Okay. No history of fever
Okay.
or cough or hemoptysis or any expectoration. Only light cough.
The light cough. Okay.
Occasional cough.
I don't see any cystic changes in the lungs.
Okay.
And I think there is some amount of bronchiectasis in the action from the left hilar region.
Okay.
Action from left hilar region. So
what are your differential diagnosis and how do you manage?
Bronchiectasis and there is no obvious any opacity in the that dilated bronchus. So I don't think it is a case of asthma.
Okay.
Then what else?
Yeah. What do you do?
I would like to do a HRCT thorax in this patient to better characterize the lesion.
Why HRCT?
The opacity is ill-defined, and I don't see. I think the bones are normal. No evidence of any erosion here.
Okay. Yeah.
Erosion.
Yeah. As you requested, we did a CT. These are the series of images you can take. Select from the series there from left side.
Okay.
These are static images. Yeah, these are static images focusing on the abnormality.
Okay. I can see there is a collapse or athletic consolidation in the left upper lobe.
Okay. Yeah.
And no evidence of any AF bronchogram in that. Okay.
Yes.
The consolidation is limited to the left hilar region.
Yeah.
So that case, it can be any endobronchial lesion with postbronchial pneumonitis here.
Okay. 1 second. Yeah. What about this?
Okay. Yeah. There are multiple heterogeneous lesions in the liver. Multiple. So at the multicentricity of the lesions, it can be secondary deposits in the liver.
Okay. Yeah. But the patient is very young to have a malignancy, non-smoker. He is around 20s or 30s.
Okay. And multicentricity, it can be hybrid cysts in the liver, hepatic hybrid cysts.
Okay. Yeah, these are the scrollable images. He has got a, as you told, he has got a left perihilar lesion with multiple liver metastatic, means possible liver lesions. So the clinical team proceeded with the further investigation of the lesion. So what is this?
Okay, there is increased uptake in the liver and as well as in the lung lesion.
Okay. So what is the study?
It is a nuclear PET study, and and I think there is increased uptake, FDG uptake in the lung lesion as well as in the liver lesions.
Okay. So what do you think?
So the primary lesion is in the left lung, in the maybe a bronchial carcinoid with secondary deposits in the liver.
Okay.
Yeah, Dr. Anil's time is up.
Okay. Yeah. Okay. Yeah. How do you think, Mohan, you did these cases?
I think I should still improve, sir.
Okay. Okay. Yeah. This is, yeah, you need to talk more and you should arrive at the diagnosis very early. At least not the diagnosis, you should tell the differential diagnosis 2 or 3. This is a quite difficult case. This is a case of bronchial carcinoid, as you told. This is because carcinoid because this is a very young patient and a non-smoker in the age of 20 with a patchy consolidation area perihilar, which was evaluated by CT chest, abdomen, and pelvis. As you see, this is a lesion, heterogeneously enhancing lesion in the perihilar, basically peribronchial lesion with multiple metastases. It's very rare for a young patient to have a carcinoma, bronchial carcinoma, and a liver metastasis at this young age. So that's raised the suspicion, and they evaluated in terms of carcinoid. And this nuclear medicine study is not a PET CT study. So this is an octorotype scan. So that's why we are not seeing increased uptake in the brain. Uptake in the brain. Asad, can you mute them? Yeah. This is the increased uptake in the liver as well as in the left hilar lesion. This is the very much particular and very much diagnostic of the carcinoid tumor. Okay.
Yes.
And again, yeah, this is the case of pseudomeningocele with the history of birth injury. The child had weakness of right arm since birth because of difficult labor, and it was imaged at the age of around 10 or 11. So now it shows typical pseudomeningocele arising from the neural foramina. So this indicates nerve root injury, avulsion injury of the nerve root from the cord. So that's how you think. And the differential diagnosis, as you told, neurofibromatosis, is less likely because it's a cystic component and not enhancing one, solid one. Okay.
Yes.
Yeah, that's the history. Important history you should ask from the clinician. History of trauma or history of as this is a child, history of birth injury. Okay. And the symptoms was from birth.
Okay.
Again, this is the classical case. And if you get a film, plain film, means it will be not a simple thing in FRCR exam. It will be question and answer will be in the same film. When if you consider a metastasis in a skeletal, means primary will be present in the same film. Okay, there for an example, bronchogenic carcinoma will be there in the edge of the film with the metastasis in the right shoulder. They will give you the right shoulder image only. Metastasis primary will be in the chest. Okay. Similarly, this is the maturing cystourethrogram showing Christmas tree appearance and the neurogenic bladder. The sacrum is present. You told sacrum is absent, but there is defect in the posterior elements of the sacrum. So spina bifida, occulta of the sacrum. Okay. Then they evaluated with the MRI lumbosacral spine. And as you told, this the low-lying conus, not at the level of L2 or L3, with the thickening of the phylum. Okay. Thickening of the phylum and also fatty deposit. Can you see this? The T1 weighted fatty phylar lipoma with low-lying and thickening phylum. So that's how patient had neurogenic bladder, and there is no lipomyelomeningocele. You told lipomyelomeningocele, that's not there. Okay, only spinal defect, spina bifida occulta. We call it as occulta. Okay.
Okay.
Yeah. So be confident whatever you tell in the exam, and arrive at differential diagnosis at the earliest moment, and try to narrow it down. And yes, and don't miss the emergencies in exam. Okay.
Okay. Okay.
Okay. Yeah, Asad, how are we doing with the time?
Yeah, thank you. So we still have 10 minutes to 7.
Okay.
So,
yeah, we can do one more candidate.
Okay. So in the meantime, we have one question.
Yeah.
Regarding the one-stop clinic you mentioned.
Yeah.
Is this the same like triple assessment?
Yes, that's the same. Triple assessment is also same. Yeah. Where patient comes to hospital once to visit the breast clinic. She will undergo clinical examination and ultrasound guided biopsy at the same day.
Okay. Okay.
Yeah, that's how. That's the practice here.
So I think the next one we have Javeria.
Okay.
Yes, hello.
Yeah, hello.
Hi.
Yeah. Okay. Yeah, these are your cases. Your first case.
Okay, so I have been provided with the frontal projection of thoracolumbar spine of an adult patient. I can see that there is diffuse hyperdense material within the large bowel, mainly the left-sided and the sigmoid colon. So this could be possibly from prior fluoroscopic imaging. So I'm looking at the bones now. Rest of the bowel is unremarkable to me, and the bones, I don't see any definite abnormality. The pedicles are all intact. The sacrum is intact. The posterior spinous processes appears in line, apart from 4, 3, 2. The L1 at the level of L2 vertebra, I can see that that there are bony processes which are next to the pedicles medially.
Okay. Can
Is
you
there any history of trauma? Yes.
please ask for the control, and can you show me with your marker, with your cursor? Yeah.
So can you see my cursor?
Yeah.
So I'm just looking at this level.
Just click at the image and show me.
Yeah. Can you see my cursor now? Yeah.
Yeah.
So
Okay.
I can just see this abnormality over here, which appears to be a bit odd than the other vertebra.
No, that's a facetal joint.
Okay. So I don't see any other abnormality. Is there any particular history which could help me?
She presented with backache.
I don't
have
see
one more
any.
view.
Okay, yes, I can. I would like to see the orthogonal view as well.
Always you should ask for orthogonal view in exam.
Yes, thank you.
That's the protocol.
Thank you. So I can see that there is some evidence of spondylolisthesis of L4 over L5 vertebra anteriorly. Yeah. And apart from that, actually the bowel is very hyperdense, the one which is containing the contrast.
Okay.
It's all projecting over the...
yeah, this is not helpful. Mostly go back to the AP frontal.
Yes.
Yeah, abnormality is in this film.
I don't see any significant, maybe the images are small, but I don't see any significant abnormality.
Okay. But the clinician is suspecting something is going on with the patient, and yeah, and they proceeded with the bone scan.
Okay. Okay, so in the bone scan, I can see multiple areas of uptake throughout the spine, in particularly the lumbar and the thoracic spine. They are very focal. So my differentials would include multifocal areas of mets in this patient. So if this is a female patient, I would recommend further evaluation with a clinician who can examine the patient in the for her breasts. So in females, breast cancers are the most common to metastasize.
Yeah, she is a known case of PFS.
Okay, so these are breast cancer mets throughout her spine, and I don't see any other focal lesions throughout her appendicular skeleton.
Okay, yeah, sure. Good. Next case.
So I've been provided with a frontal projection of abdomen and pelvis of a skeletally immature patient. So I'm looking for any obvious abnormality. I'm concentrating on the bones at the moment. The visualized bones appear unremarkable. Apart from like the left, possibly the left epiphysis of the femur appears slightly reduced in height as compared to the right one. So is there any history which could guide me towards the right hip joint? Is there abnormality in the right hip joint?
The patient has right hip hip joint pain, hip pain.
Right.
Yeah, right hip pain.
Okay. So apart from some fullness of the fat planes, I don't see any other abnormality, although I was suspecting that the epiphysis of the left femur was a bit smaller as compared to the right side.
Okay, but patient is telling right hip pain.
So the fat planes are distended on the right side. The epiphysis and appears unremarkable. I can see a loosened area within the metaphysis of the right femur as well.
Okay.
Other than that, I don't see any other abnormality in the visualized bones and the soft tissues.
Okay, yeah.
So I would, yes, I would inform the referring physician and would recommend an urgent evaluation with the pediatrician for this patient. And I would review if any prior imaging is available also, and also more clinical history would be more helpful for me. Okay, to narrow down, to think more of the differentials.
Okay, yeah. As this is a child, he can tell only pain. So that's okay, no problem. We proceeded with the MRI. You can click and scroll the images.
Okay, so I've been provided with the axial MR images of the same child. I can see that there is an abnormality within the right iliac bone. And as I proceed further inferiorly, okay, so I cannot see more inferior images. So this abnormality is in the left iliac bone. I can see that there is some, it is a bit hyper intense on this fat spread sequence. So possibly, and the cortices are also a bit intact or laterally, apart from some soft tissue extending medially, with some hyper intense signal extending along the muscles, psoas muscles. So I'm in this age group, I'm suspecting LCH.
Okay.
And
what else? Your different.
I would not keep neuroblastoma meds because this appears to be a bigger child.
Okay.
And the lesion is a bit corticated.
Okay.
Other than that, I cannot take anything other than that.
Okay, no problem.
But this appears to be a benign lesion looking at the MRI sequences, sequences. Yeah.
Okay, no problem. Yeah, our next case. This is a 50-year-old female presented with acute right-sided pleuritic chest pain, breathlessness with high D-dimer.
Okay.
Yeah, again, you click on the center of the image and start scrolling.
Okay, so I've been provided with axial contrast and sequence images of a CT scan images of a 50 years old female who has presented with pleuritic chest pain and high D dimers. I'm scrolling the images in cranial caudal dimension as I'm looking the images closely as well to find any discrete abnormality. So in first glance, I can see that there is some abnormality which is involving the, which is causing, there's soft tissue which is causing narrowing of the right main pulmonary trunk and at the hilum as well. I can see that there is this soft tissue abnormality there. It does not appears to be like it's not tracking along the other vasculature. It's just very focal up to the right hilum. apart from that, I can see some diffuse thickening along the arch of aorta as well.
Okay.
Other than that, I don't see any other abnormality, no obvious lymphadenopathy in the mediastinum.
Okay, the clinician is suspecting PE, and what do you tell them?
The visualized pulmonary arteries and the segmental and subsegmental branches are all opacified. I'm just the right main pulmonary trunk is narrowed down because of this circumferential soft tissue thickening.
Okay. Yeah, the clinician is asking, is it a thrombus or not? Do I need to thrombolize or not?
It doesn't seems to be thrombus. It's just very it's very circumferential. It's just thickening around the vessel.
Okay. Yeah. What do you tell them?
So I don't think so that it's a thrombosis.
Okay.
And is this some? Yeah, I'm thinking of some infiltrative process which is involving the right pulmonary artery and the aorta.
Okay. Yeah.
So I'm thinking on the lines of vasculitis.
Okay.
And other than that, or any like this is very it's all soft tissue. So I would like to. Is there any other significant history which can be provided for this patient?
Yeah, she has history of hypertension also.
Okay, so I was as I am suspecting vasculitis, so I'm thinking on the lines of polyarteritis nodosa, because she has hypertension as well.
Okay.
So I would inform the referring physician, and I would refer this patient for further management and discussion in the appropriate MDT.
Okay. Yeah, the child neonatal X-ray with some medical issues.
Okay, so this is a frontal projection of a child, chest projection of a child. I can see some lucencies involving the right lung, in particularly the upper and the mid lung zone, the contralateral left lung, and the right lower lung zone appears apparently unremarkable. There is no significant midline shift towards the contralateral side of the mediastinum.
Okay.
No pleural effusions or significant pneumothorax is noted. Rest of the visualized bones appears unremarkable. So in a child, I would suspect my differentials would be CPAM or although there is I can see lung between the lesion and the in between the right hemidiaphragm and the lesion. So I'm not suspecting my second differential would be hernia, which is not usually it's not the usual side in children. It's mostly on the left side.
Yeah.
So other than that, I could, if the child is sick, my second differential would be a lung abscess, but this is a very big lesion. This. So
inflammatory markers are normal.
Okay. So I would like to see if there are any prior imaging of this patient. Otherwise, my differentials, my top differential would be a congenital pulmonary malformation.
Okay, yeah. And we followed it up with a series of X-rays. This is the chest X-ray at 6 months of age.
Yeah, Dr. Anil, time is up.
Okay, yeah, this is the case. This is the last case we finished.
So there is interval significant improvement in that multicystic abnormality, which was involving the right upper lung zone and right upper mid lung zone.
Yeah.
I think there was a superimposed infection sorry, the history says that the inflammatory markers were fine for that patient. I cannot think something else looking at the picture of the prior.
Yes, this is CPAM only.
Okay.
This is the CT at 6 months of age. This is how it looks. Okay. Actually, this was picked up on the antenatal scan, and that's why they took an X-ray at birth at day 0, and they serially followed up with the patient symptoms, and this is how at the 6 months of age. Okay.
Okay. Thank you.
Yeah. So yeah, you did well. You arrived at diagnosis in all the cases. Very nice. Okay, this case is a CPAM, and yeah, this is a previous case. This high D-dimer does not mean a thrombus, and as you rightly picked up, this is a diffuse thickening of the walls of pulmonary artery, and you can see the arterial wall thickening, aorta also, and there is no subclavian artery. You see, subclavian artery is not ossified. Left common carotid is also showing diffuse thickening, and right CCA is also. So this is a case of Takayasu arteritis.
Oh, okay, thank you.
Yeah, Takayasu arteritis. This is the presentation, and you are right in telling the vasculitis and differentials. So this has to be managed like that. Okay. And previous images, yeah, this is the lucent lesion. Can you see?
Yes. Okay,
Yeah.
I was making the lucent lesion in the femur.
Oh, yeah. Yeah, but you see the preperitoneal fat plan, it comes like this and ends like here. So anything away from the, apart from the lateral to this line is bony abnormality, not the bowel shadow. So you compare the same line on the right side also. This is outside the preperitoneal fat plan. Okay. Yeah. Then you should suspect a bony lesion. After that, you rightly picked up. This is a right iliac bone lucent lesion in a child. This is a case of Langerhans cell histiocytosis. And differential diagnosis of metastasis are less likely, and Ewing sarcoma is also less likely. Okay. Yeah.
Was there a birthes or like I think I was thinking that the left femoral epiphysis was also smaller. Okay.
No, it may be apparent, but the patient's symptoms was on right side.
Okay.
Okay. Yeah. You should go with the patient symptoms.
Okay. Thank you.
Yeah. Your next case, first case. Can you see the abnormality now?
Yes.
Can you point out?
Yeah, so there is this increase, there's some sclerosis, and there's this absent left pedicle also.
Yeah. This is the pedicle of L1. There is no pedicle on L2.
Yes,
so
you're
this
right.
is absent pedicle side. This is classical of metastasis in a breast carcinoma or any other malignancy. So this is a case of metastatic lesion involving the spine from a CF breast. So this is winking owl sign.
Yes.
Okay. Yeah. So I think these are your cases. You did well.
Thank you.
Yeah, all the best.
Thank you for such nice cases. Thank you.
Okay. Hi, Asad. I think we did with all the candidates, right?
Yes, hi. So yeah, we are done with 5 candidates instead of 4. If you want to do one more,
I
that's
don't
up to
have
you.
much images. Okay, we'll see.
Do we have the last candidate with us?
Yes, I am here.
Okay.
Hi, Ali Mansoor.
Hi.
Yeah, hi. Okay, yeah, next case for you.
Okay. So this is a 55 years old female who has presented with abdominal pain and vomiting, and there is generalized abdominal tenderness and involuntary guarding.
Yeah, sorry. Yeah.
So
this is your X-ray. Yeah.
So this is a 50 years old female who has presented with generalized abdominal distension and pain. What I can appreciate is that there are multiple dilated bowel loops within the central abdomen, and these appear to to have some air in their walls as well, suggestive of pneumatosis. I am I can appreciate that there is a lucency which seems to be projected over the right inferior pubic ramus. I am trying to look for any signs of pneumoperitoneum in this patient. I cannot appreciate any definite free air in on this X-ray, and there are no definite lucencies projected over the liver, so there is no definite portal venous air. So in this patient, I am concerned for possibility of small bowel obstruction with pneumatosis, possibly due to a hernia. I would like to correlate clinically with the coordinate with the clinician if this patient has any hernia on examination and would like to proceed
Yeah, he
further
says
with
no
CT.
hernia on examination.
Okay. However, I would like to evaluate further with CT abdomen with contrast.
Okay. Yeah. Before that, the clinician is asking whether it has perforated or not.
I'll review again to see if I can see any definite signs of pneumoperitoneum on this. I cannot, there is this faint lucency in the upper abdomen, which does not confirm to definite air within the bowel. I can, there is strong clinical suspicion of a perforation. I can confirm further with erect or lateral shoot through to confirm if there is any perforation.
Okay. Yeah, your next case.
So I've been provided with a 45 years old female who has right lower abdominal pain, fever and vomiting. There are elevated inflammatory markers and clinical suspicion of appendicitis or pelvic inflammatory disease.
Okay. Yeah, you can request for the remote control and yeah, you can click on the center of the image and start scrolling.
Okay, so I have been provided with CT scan axial performed with oral contrast of an adult female who has presented with abdominal pain and there is suspicion of appendicitis versus pelvic inflammatory disease. I am scrolling craniocaudally, and now I'm again having a look caudocranially to have a look at the area of concern in the I'm trying to locate the appendix first to see if it appears inflamed or not. However, what I can appreciate is that there seems to be a filling defect within the right. Let me trace the vessel. There is a filling defect within the right iliac vein. So this is concerning for possibility of thrombosis. I'm trying to look for any cause of this thrombosis, such as any inflammation. I'm trying to locate the appendix. I am unable to locate the appendix. I cannot appreciate any significant adnexal pathology.
Okay.
On this.
The clinician is asking what could be the cause of your thrombosis. You told right iliac vein thrombosis, right?
Yes.
Yeah.
So this could be due to a pelvic inflammatory disease. However, I cannot see any definite cause, any definite pelvic inflammatory disease. This could be due to, I'm trying to look if there is any ovarian vein thrombosis as it can lead, or this can be due to some malignancy which could be compressing. However, I cannot see anything compressing the iliac vein. There seems to be this nodule in the left adrenal gland, or no. I'm scrolling further cranially to see if I can see any abnormality in upper abdomen. However, the upper abdomen seems unremarkable. So what basically I have found up till now is that there is right iliac vein thrombosis. However, I have been unable to see any definite cause of this of this right iliac vein thrombosis. However, I will urgently convey my findings to the referring physician that this patient needs anticoagulation for this thrombosis.
The patient gives a history of recent delivery.
Okay, then this can be due to a purpureal hypercoagulable state leading to ovarian vein thrombosis, which can then, as ovarian vein drains into the iliac vein, so it can then be disposed to iliac vein thrombosis.
Okay, okay, good. Actually, this was my first FRCR exam case, Viva case. Okay, we'll move to next case. Yeah, next one.
So this is a 70-year-old female who has presented with abdominal pain and bloating. There is iron deficiency anemia.
Okay.
So I've been provided with frontal chest radiograph of a female patient who has a bloating and pain, and there is iron deficiency anemia. I am looking at both lung fields. Both lung fields appear grossly unremarkable. The cardio-mediastinal outlines appear preserved. Bilateral costophrenic angles are clear. There appears to be slight opacity in the right apical zone. However, this could possibly be projectional. I am looking at the bones. The bones seem grossly unremarkable to me. I'm looking at my review areas. There is no retrocardiac opacity. Bilateral hyla appear unremarkable. So in this patient with iron deficiency anemia and bloating, I am trying to look for any associated abnormality. However, I am unable to see any definite abnormality on this chest radiograph.
Okay, so what are your review areas on chest X-ray?
I would like to the apices, the retrocardiac area below the diaphragm, the hyla. I cannot appreciate any retrocardiac. There is slight bulge on the right paravertebral region. However, that is possibly projected.
Okay, okay. Yeah, however, clinicians suspected some abnormality and they proceeded with a CT further. You can look at the CT images further. Next, you have the control, click on the center of the image and start scrolling. You can choose either of the windows, lung window or mediastinal window.
Okay, I've been provided with CT chest mediastinal window with plain images without contrast. I am scrolling craniocaudally and having a quick look first to see for the cause of abdominal pain, for pain and dysphagia in this patient. I'm having a look, now I'm scrolling caudocranially to see any definite abnormality. I can appreciate that there seems to be some enlargement of the left atrium, possibly appears slightly enlarged. I'll have a look at the lung windows too before I narrow down my differential possibilities. So I'm scrolling craniocaudally in the lung window. Up now I can see that both lungs appear clear. I cannot appreciate any nodule or any major collapse or consolidation. I'm scrolling caudoclinally. I cannot. So there is this a patch of fibrosis at the right, at the left apex with some speculations.
Okay.
So in an old age patient, I would be concerned about this and would like to compare this with if any previous imaging is available. However, this cannot be responsible for the patient symptoms. So I will like to have a look at the mediastinal window again to see the cause for dysphagia of this patient. So I'm looking at the stomach. The stomach seems
stomach was normal, esophagus was also normal. So what do you tell the clinician now?
So I would tell the clinician that there is a fibrotic patch at the left lung apex with speculated margins. I would like to compare this with previous imaging as
No previous images were available.
However, in an old age patient, I would be concerned about this being a possible sinister pathology. However, since this patient has presented with dysphagia also, and I am unable to see any gross abnormality which could be responsible for dysphagia in this patient, I would also ask the referring physician that we can proceed with an upper GI contrast study in this patient to look for the cause of dysphagia.
Okay, yeah, next case.
So this is a 20 years old male with chest and left thigh pain, no trauma, traveling interstate. So this is a frontal chest radiograph of a skeletally mature patient. I can appreciate that there is a reduction in left lung volume with some abnormal configuration of the upper ribs. I can also appreciate that there is an opacity in the retrocardiac region just above the left hemidiaphragm, which possibly appears calcified. Apart from that, I can appreciate that there are further opacities projected over the left lower hemithorax, which are possibly related to the associated ribs. Apart from that, both lung fields appear grossly unremarkable with no definite other lesion seen. Bilateral costophrenic angles appear acute. Rest of the visualized bones appear grossly unremarkable. So this patient with left thigh pain with a calcified nodule in the retrocardiac region, I would this could possibly represent a calcified. I would like to do a lateral chest radiograph if available to see further localize this abnormality, whether it is related to the heart or it is located within the lung.
Actually, lateral X-ray is not done in UK.
Okay. So then I would like to proceed with CT chest to further delineate this.
Okay, yeah, you can have a look at the lateral X-ray.
Okay, on the lateral chest radiograph, this opacity seems to be located in the posterior mediastinum and is related to the vertebra actually.
Okay.
So
what are your differential diagnosis?
So in this patient, where I could see multiple other lesions which were related to the ribs, and there is this rounded lesion related to the vertebra, and this patient has presented with thigh pain. A possibility would be for multiple osteochondromas. I would like
time is up.
Yeah, we'll finish with this case.
I would like to correlate if any previous imaging is available, and would like if to see any and would like to correlate with the patient's symptoms, and would like to follow up this patient
Yes.
with imaging.
Yes, you are right. This is a case of multiple exhaustosis or diaphyseal ectasia. This is one exhaustosis. This is one here. These are the sessile one. These are the polypoidal one. You can see multiple. There are multiple are there. You here also wherever the bones are abnormal, they're all having exhaustosis. Okay. So as you rightly told, this thigh pain is also because of exhaustosis. I think this is imaged. This he has multiple exhaustosis. Case of diaphyseal ectasia. Okay. Good. So coming to your previous case, this is a case. Can you see the abnormality now, Ali?
No.
Can you see?
Okay. Yes.
Yeah, this is the abnormality. This is the carcinoma lung. This is the carcinoma lung. That's why the weight loss. He was also presenting with weight loss, and his dysphagia symptoms may not be related to this, but he had a lesion at the left apical region. So this is your review area. Okay, you should consider this. This is early stage of lung cancer. And this is appendicitis. This is a case of right ovarian vein thrombosis. You can see this. This is the IVC. This is the dilated enlarged vein coming and draining to the IVC. So this is the right gonadal vein thrombosis. Because of there is congestion of the pelvic vessels. You can see bilateral parauterine vessels are engorged. There is pelvic inflammatory disease, and here she has got ovarian thrombosis also. Iliac veins are fine. Okay. See, this is the iliac vein, external iliac vein coming here and joining. This is the common iliac and IVC. This was my exam case, first case. Okay. You did well. Ali, all the best.
Okay. Thank you.
Okay. Asad.
Yeah, thank you so much, Dr. Anil. There is one question in the chat box that was regarding the management of Takayasu's arteritis.
That will go to vascular clinic, vascular surgical clinic. Basically, the treatment of choice is steroids, anti-inflammatory. Steroids is the drug of choice, and then they will serially follow up with the imaging.
And also we can mention about the rheumatology referral.
Not exactly. This is not related to rheumatology.
Okay. Thank you.
Anything else? Any other?
There was another case too for this one.
Which one? Before this? Okay, sorry, I forgot it. Which one? Abdominal pain, vomiting, tenderness. This is a case of perforation. Can you see the perforation here? Signs of perforation.
Okay. Yes. Now this.
You were right. This is a case of obstructed bowel with pneumatosis and perforation.
Okay.
There is no hernia. You are right at pointing out the hernial orifices and also the liver shadow to look at the portal venous gas. But you can see the regular sign here. Can you see the both ends of the bowel wall? On either side, you can see the lucency. That's the regular sign. You can also see here. So this is a perforation, small bowel obstruction, pneumatosis, and perforation. Good. So basically, all the emergencies, you should never miss emergencies in FRCR. Not only in FRCR, in life also. That's the motto. Asad, any other questions? Any more questions?
Thank you so much, Dr. Anil, for your time.
Thank you, Asad.
It was wonderful having you.
Thank you, Sabat, and thank you, team FRCR 2B.
And thank you all the candidates.
Yes, all the candidates also, and all the best to everyone. And any other general questions I can answer you?
Thank you very much, Dr. Anil. And you did 6 candidates in this session. So thanks are done. You made one bonus and excellent cases. So thank you so much. If anybody has more questions, you can put in the group of Telegram. And Dr. Anil will do it. Thank you so much for your time. We will not hold you any longer, Dr. Anil. Thank you.
Thank you very much.
Thanks a lot.
All the best. All the best to all the candidates. Okay. Okay. Bye.
Bye, everyone.
Bye.